Hi, my name is Dr. Jeremy Williams, and I'm with the Breathing and Sleep Center of Colorado Springs. And I'm here to talk with you about some non-surgical treatment options of treating obstructive sleep apnea. There's a silent crisis going on in America where a lot of us suffer from a number of some of these benign conditions that can eventually grow to be some more serious conditions. So when I say benign conditions, things like crowded teeth or snoring to a degree, mouth breathing, but over time, some of these things can actually start to lead to more serious concerns, especially with diabetes, Alzheimer's, dementia, cardiovascular disease risk, and sleep apnea. And what we find is that a lot of these symptoms that start to show up have a common root cause, which is a compromised airway. So what I mean by that is the space of how we take air, going from the tip of the nose to the base of the throat, we want that to be as wide open as possible, so it's very easy for us to get that air from the outside all the way through our lungs. And as we'll get to in a few minutes, there are a number of things that can compromise that and make that space a little bit smaller and make it harder then for air to be able to travel all the way through down to our lungs successfully and unobstructed. The way that we sleep has a very strong impact through everything in our body, how we function during the day, but all the way down to our genes. And so there was some very interesting research that was done where they took a control group of patients and had them sleep for 8 hours, 6 nights in a row. And then they took a study group of patients and they only slept for 6 hours, 6 days in a row. And what they found is with that study group, they had 711 genes that were altered as a result from just 2 hours less of sleep a night. And when we're talking about 2 hours less of sleep per night, we actually refer to that as sleep deprivation. And so this study group had 711 total genes that were compromised just as a result of having 2 hours less of sleep. And half of those genes were downregulated and another half of those genes were upregulated. The genes that were downregulated were responsible for our immune function, and the genes that were upregulated were responsible for tumor proliferation, chronic systemic inflammation, and cardiovascular disease. It's so important that not only are we getting the proper time of sleep, but we're also getting good quality sleep. And what I mean by that is there's a series of sleep stages that we enter into, from being awake to a couple light stage sleep, slow wave deep sleep, and REM sleep. And it is in deep sleep and REM sleep where our body is able to restore itself. We get restored physically, our battery recharges, but then also as we enter into REM sleep, that's where our brain and our mind get its rest over its 24-hour period. And when there's compromises in how we breathe, it disrupts those sleep stages. We will actually go awake out of those deeper stages of sleep and into more light stages of sleep. And so sleep deprivation doesn't necessarily mean that we're staying awake every single day for a 72-hour period stretch. It can just mean that we're just not getting a full amount of deep restorative sleep each and every night. So the underlying cause with a lot of these symptoms, such as crooked teeth, snoring, mouth breathing, obstructive sleep apnea, has an underlying cause of a compromised airway. But what is the root cause of that compromised airway? And what we find is that there's a number of possible root causes that can close that airway and make it harder for us to be able to breathe. So one is having just a more narrow, high vaulted palate, where there's not enough space in our mouth for our tongue. Another could be that there's an undiagnosed tongue tie that keeps the tongue from being able to fully be on the roof of the mouth out of the throat space. We can also have a weaker muscle tone, where the tongue is just resting on the floor of the mouth in the mouth breathing position, where it's a little bit closer to the back of the throat and it's taking up space inside the throat. Basically, the difference between what's normal and what could start to obstruct us is that when we're sleeping, we want our tongue to be completely pressed up onto the roof of the mouth. so that as we're going into the deeper stages of sleep, especially REM, where we do our dreaming, before we enter into REM, our brain goes into sleep paralysis. And it makes it so that we don't act out our dreams. All of our voluntary muscles are able to relax. And when we're entering into REM sleep, we want our tongue to just be holding its suction right there on the roof of the mouth. It keeps that throat space open. And so air is able to travel completely unobstructed from the tip of the nose all the way down into our lungs. But what happens is that when there's issues with how well we can breathe, we start to get a little bit stuffy through the nose, and we compensate by opening our lips and breathing through the mouth. As soon as our lips open, the tongue drops from the roof of the mouth to the floor of the mouth and back. And when it goes back, it starts to pinch the airway space. And so in normal anatomy and function, we would have an airway space that's more like a garden hose tube. But when we have obstructive sleep apnea and the tongue starts to relax and fall into the throat, that garden hose becomes more like a coffee straw. So what is the root cause of some of these things? Now, Stanford Sleep Medicine came out with some research that was very interesting, and what we found is that they refer to a hidden epidemic of shrunken jaws. And so what that means is that over time, we've noticed that the jaws, the lower third of the face, are continually getting smaller and smaller. They're getting smaller in a width dimension, and instead of growing wide and down and forward, we're getting narrow and growing backward. And the concern with that is that the jaws are kind of like the white picket fence, and the yard is our tongue. So what happens is if we're trying to bring that fence in tighter, there's no more yard space, and that yard actually gets pushed back into the house, which is our airway. Now, when we're talking about obstructive sleep apnea, quite commonly, we've been referring to that as a condition that adults suffer with. But what we find is that the root causes of when these develop actually start much younger. No one ever just develops sleep apnea when they're 45. And so when we're talking about the jaws being more narrow and pushing the tongue back into the throat space, that actually goes back to our growth and development. And when we're looking at these kids here, there's some signs that we can see that they're struggling. So this first boy, we can see right here, he has that double chin, the protruded lip. The girl in the middle, we can tell she has those dark circles, the bags under her eyes. She has some chapped lips from mouth breathing and a dimpled chin there. And that boy on the right, he has a double chin, also with the dimpled chin, some dark circles around his eyes. The younger that we go, we can continue to see these symptoms. What we're looking at is this girl on the left, she has the bags under her eyes, but she has this small chin and a head tilt. The girl in the middle is unable to, keep her mouth together at rest. And so there's some teeth showing. She has a very, very small chin. And the girl on the right is just excessively tired, has had some behavioral issues. And so these are some signs that some children are actually struggling with some sleep issues that if we did nothing at all, they would actually grow and develop more to be some more serious sleep issues that stick around into adulthood all the way to the end. And so ideal normal craniofacial growth is that we grow down and forward of the lower third of the face. So in our first 2 years, this is where we're at that line, and the further line is where we grow in 17 years. And so what we see is that the majority of the cranium is already developed at 2 years, and the remaining years is where we have development of the lower third of the face and the mid face, which is primarily our jaws, the upper jaw and the lower jaw. Now, by the time you're 2 years old, 50% of the skull has been developed. By the time we're 4 years old, we're at about 75%. And by the time we're 12 years old, we're nearly 90-95% fully developed in our cranium. And so it is during these years where if there's an event with our breathing, issues with our tongue, and that tongue isn't able to adequately stimulate the growth of the jaws, those jaws will just end up getting put on pause. So we want to have some wide forward downward growth of the face. Say if an event happened where we just stopped growing at one of these middle lines, what happens is that our tongue still continues to grow to be the same size our genetic blueprint designed it to be. And instead of being able to have space to move into, it only will get pushed back into the throat space. And so looking at ideal anatomy, this is our functional airway where air goes through the nasal cavity. There, 3 pumps happen. There's a cleaning pump that turns on that filters the air, helps to get rid of the pathogens that are in the air that we can't see. So for example, the common cold virus. As we breathe and our tongue is resting on the roof of the mouth, that air that's getting forced to go through this whole filtration center, nitric oxide also gets released into our sinuses, which helps to also filter out the air and clean the air as we're breathing it. Also, as we're breathing through the nose, that air gets warmed and humidified, so that by the time it gets to our lungs, it's the proper conditions for gas exchange between oxygen and carbon dioxide. And so what we see is that we want that air to be able to follow through a hallway that's completely unobstructed. And as that air goes through the nasal cavity and down into the throat, there's a couple potential obstacles for obstruction. One is the soft palate, and the primary bully of all of these obstructions is the tongue. So when we go back to craniofacial growth and development, if instead of those jaws growing down and forward, they just stay narrow and grow backward, it's going to push that tongue into that functional airway space. These are some common symptoms that we see today, where as we're growing, crooked teeth has just become very, very common in our culture. And it's almost become a rite of passage for a child to get their wisdom teeth taken out and also have braces put on. The interesting thing is that crooked teeth is a modern day phenomenon. The need to have braces is a modern day phenomenon. Several hundred years ago, there weren't oral surgeons and there weren't orthodontists. And it's very interesting that when we look at these anthropologist skulls from several hundred years ago, all of the teeth are straight, they're not crooked, and they all have 32 teeth. And they did that without needing to have braces put on the teeth. And so when we look at Dr. Robert Corricini's research, he's a dental anthropologist, and his research is very, very interesting. And what he found, looking at hundreds of skulls from as long as 400 years ago, he found that these skulls all had straight teeth, and they all had 32 teeth. What we're looking at is population studies where we're comparing groups of people in rural areas that are isolated from like westernized diet influences, as well as from just the skulls from several hundred years ago. And what he found when he studied these populations that were isolated and rural is that they had the same jaws that developed just as these skulls from a few hundred years ago. And what contributed to that was that they were breastfeeding their infants for significantly longer than we do in our society today. So instead of breastfeeding for 3 months and then switching to a bottle because mom has to go back to work, they were breastfeeding for a few years. And then from there, they would convert to eating hard fibrous foods. So they would have dried meat, hard root vegetables. And what that tougher consistency does is it helps to grow the jaws. And so in our body, muscle influences the growth of bone. So say, for example, if we're going to be lifting weights, over time as our muscle grows from the weight lifting, that bone also gets a little bit bigger and stronger and more dense to help support that muscle and the function that that muscle is doing. And our jaws are just the same. So if we grow up being able to nurse from our mothers and developing a proper swallow pattern, the facial muscles start to get stronger, our tongue starts to get stronger, and then as we eat harder fibrous food, that allows our chewing muscles to get stronger. And so as these muscles are getting stronger, it's helping to promote the jaws to grow wider and then down and forward. And when we look at the skulls from a few hundred years ago to today, not only are the jaws getting more narrow, but what happens is that, if we think of the jaws, they're the foundations for the teeth. So if the jaws are able to grow wide, they create plenty of space for all the future adult teeth to move into. which is why these skulls from a few hundred years ago had all of the teeth. They all had 32 teeth, compared to today where wisdom teeth are pulled, and in some cases, teeth are pulled for the sake of making space to then make them straight with braces. And so what he was interested in was, is this something that's genetic, or is this something that's environmentally influenced and acquired or adapted? And what he found that as he studied these rural populations, they would have these very wide developed jaws, just as they did in the skulls he was finding from a few hundred years ago. But when they moved into the Western diet and kind of the Western culture and started adopting those diets and softer foods, as the foods got smaller, so did the jaws. So what he found as he was studying these groups of rural populations, when they moved to a Western culture and adopted their diet, he found that the jaws started shrinking. And so the children of these populations, half of them, would end up with some trait of what we call malocclusion, meaning crooked teeth, not enough space in the mouth for the teeth. The second generation would have 70% of that generation would show traits of malocclusion. And by the third generation, 85% would have traits of crooked teeth or not enough space in the jaws. And we are several generations past the point of industrialization of our food source when our foods start getting softer here. And so it is very, very common. About 95% of kids these days have a degree of crooked teeth where they need to have some sort of orthodontic intervention. And so what we learn from this is that it is not genetic. It's completely acquired and adapted by our environment. And the reason is that if this were genetic, in order to show 50% of the population within one generation, instead of 20 years, if that were genetic, it would take 27,000 years to start to show up in 50% of a population. And so crooked teeth is not inherited. It is completely based on our influences. And so the primary influences are inadequate breastfeeding. When we breastfeed, that strengthens our tongue, it strengthens our oral facial muscles, and that helps to develop a proper swallow pattern. And as we're swallowing, our tongue is resting up on the roof of the mouth and it's pressing against the bone. And so just by being able to strengthen those muscles, and anytime we swallow, our very strong tongue is able to get up and start then to stimulate the growth of the upper jaw. But if instead of breastfeeding long enough, we instead go to a bottle where it takes no effort at all to be able to drink, instead we just can turn the bottle upside down and it will just drip for us. It requires no effort to be able to kind of extract that liquid from the bottle. All a child has to do is just to be able to swallow. And there's no development at all with those facial muscles. We also have, it's very common to have significantly softer foods. And so, for example, I grew up on baby food where all of the machines did the chewing for me instead of my jaws. And all I had to do is just slurp this pureed food. And so as a result, there was no exercise done for those muscles and the jaws just grew to be a little bit more narrow. And so in a perfect world, ideally, we want to be able to convert to having some harder fibrous foods as soon as possible. And there's some methods called baby-led weaning, for example, that can help to allow a child to start to have these more harder fibrous root foods without the risk of being able to, aspirate it or breathe it in. As I was saying earlier, as we swallow, the tongue should be pressing up onto the roof of the mouth. But that's also how that upper jaw grows. And so the tongue is the scaffold for the upper jaw. So as the tongue is getting up there and it's just resting up there as we're breathing or when we swallow, what it's doing is it's helping to stimulate the growth of the palate. So what happens is that it's able to create the space that it needs in between the teeth and finding that home there. But for a number of reasons, if the tongue isn't getting up there and it's just resting on the floor of the mouth, either because of a low muscle tone or an undiagnosed tongue tie or mouth breathing habits, that palate doesn't get stimulated, and that can just cause then the upper jaw to become more narrow. So when we look at the jaws, it's important to remember that the roof of the mouth, which is the upper jaw, is also the floor of the nose. So when we're looking at, say, for example, this picture showing the V-shaped arch that we commonly see today in comparison with what it is ideal with a broad U-shaped arch over on the right, we see these kind of inverted skulls right below them. And that yellow arrow is showing us that the width of the space in between the teeth has a direct correlation to the width of the space that's in the nasal cavity, illustrated by the green arrow. So when we're looking at, say, a modern day jaw, we see it's a lot more narrow and there's just less breathing volume and breathing space in the nasal cavity as a result of developing a more narrow jaw compared to this skull from a few hundred years ago where there's plenty of space in between the teeth, illustrated by the yellow arrow, which creates a much wider nasal volume space and a better ability to breathe through the nose. Now, Dr. Christian Guilleminault is a pioneer in sleep medicine, and he was at Stanford University for a number of his years. What he found was that maxillary expansion could be a very valid treatment of being able to treat obstructive sleep apnea. Now, when we're looking at the skull, when all of those little fine bones come together, that's called a suture, that joint there. Previously, it had been thought that when we pass through puberty, those joints completely close. But those joints actually stay open all the way into our early 80s. And in between those joints are stem cells. And with these stem cells, they want to be able to build bone. In addition to being able to provide maxillary expansion surgically, if we know what can turn these stem cells on and turn them off, we can turn them on and off like a light switch. And we actually have an appliance that our patients wear that allows them to grow that upper jaw non-surgically by being able to turn on these stem cells. We encourage you to come in for a records appointment because then we're able to evaluate with a 3D X-ray the quality of the airway space. So is it the size of a garden hose, or is there constrictions that's making it so that you're breathing through more of a coffee straw when you're trying to sleep? The very first goal of all of our treatment is that we want to improve the ability to breathe well through your nose. Breathing through the nose is imperative for good sleep quality, but it's also the first line of defense of our immune system. So when we breathe through the nose, our tongue is resting on the roof of the mouth, and that helps to stimulate the release of nitric oxide through our sinuses. And as nitric oxide is getting released through the sinuses, there's a number of things that it does. One is it helps to improve the ability for oxygen to be traveling through our bloodstream. But it's also a very potent vasodilator, so it's opening up those arteries even more, so even more oxygen is traveling through the arteries. But it's also a very strong antimicrobial and antiviral gas. And so as we're breathing through the nose, it's helping to kind of filter out the things that we don't want coming into our body. And when we breathe through our mouth, we skip all of that. When we're looking at what could potentially compromise an airway, when we're breathing through the nose, the picture on the left shows our tongue resting all the way up on the roof of the mouth. And when it's resting up onto the roof of the mouth, that's keeping that throat space completely open. But as soon as the lips open and the tongue drops to the floor of the mouth, it drops back and it starts to take up space into the throat. And what happens then is that as we're breathing only through the mouth, none of that air is getting filtered, it's not getting warmed, it's not getting humidified, so it's not the best conditions for gas exchange. But we can just get that dirty air then that's hitting the back of the throat where the tonsils are, and that can contribute to some micro trauma of the tonsils, which naturally cause them to get very angry and start to get more swollen. Now, as tonsils swell and the adenoid tissue swells, that starts to take away from that airway space. And that garden hose starts to become more of a straw and a coffee straw the further down we go. And when they start to get so swollen past the point of no return, we have to have ENTs on board to surgically remove that tissue to be able to open up the airway even more. But unless that root cause of the problem, how did the tonsils swell in the first place? How did the adenoid tissue swell in the first place? If that's not addressed, that tonsil tissue and that adenoid tissue can actually grow back after surgery. And so it's imperative for us that we focus on nasal breathing first and being able to improve how well you breathe through your nose, because that is the most important factor of being able to have good quality sleep and being able to feel better. Now, there was some very interesting research done by Dr. Harvold, done several decades ago. And what he did was he took rhesus monkeys and he plugged their nose shut. And what he found is that as that nose was plugged shut, over time, they would start to develop a more narrow facial structure as a result of the tongue continually resting on the floor of the mouth. So as the tongue rests on the floor of the mouth and the mouth is continually open from breathing, the face starts to get more narrow and long, and these monkeys would then start to develop a tongue thrust habit where they're pushing their tongue outward to be able to just open up their airway. As the face gets more narrow, there's no space for the tongue. And so instead of just basically trying to get it out of the throat, the tongue thrust pushes the tongue outward to then open up the throat space. One of the most common symptoms that we see with a lot of children that we work with is what we call attention deficit disorder. And attention deficit disorder and ADHD is becoming so common in diagnosis with so many of the children in our communities. And we see it more so as a symptom rather than a diagnosis. And there's some very interesting research that was done that took 11,000 children in this 7-year study. And as Dr. Karen Bonnick observed them, what she found was the children who had sleep-related disordered breathing had a 60% increase in receiving an ADHD diagnosis. So that's a better chance than a coin flip for a child to be diagnosed and then prescribed adult dosage amphetamines. And what they found was that during these years, instead of their IQ improving as they're learning, their IQ scores of those children who breathe through their mouth actually declined as a result of having sleep disordered breathing. Another common symptom that we see a lot, especially with children, is bedwetting. And the reason is that when our breathing starts to get disrupted, our brain starts to go into fight or flight mode. And when it goes into fight or flight mode, it's going to take energy from areas that don't need that and put it into the most critical areas that are needed. So for example, our brain, our muscle tissue, our eyes, they're all going to be receiving this attention so that we can make sure that with whatever the danger is to us, whether it's a tiger that jumps over the tiger fence in front of us or a grizzly bear that's out in the wild, we can do everything that we need to be able to fight for our life. But when we go into fight or flight mode, that sense of danger is the same to our brain, whether it's a tiger jumping over the fence or an obstruction in our airway. It doesn't know what's going on, it just knows that there's a danger to our life. And so what happens is that as a child is struggling to breathe in their sleep, they're actually in fight or flight mode even though they're asleep. They're unable to control some of those muscles that are responsible for being able to kind of like hold the bladder. And so the bladder just relaxes, the sphincters relax, and they're able to just void and wet the bed. And we see this a lot, and it's quite common in children. It's just not really talked about all that often because it's not something that parents usually brag to each other about. Over time, if the issue doesn't get addressed, we naturally grow out of bedwetting, but instead into adulthood, we're waking up 2, 3, 4, and several times a night to just wake up to go to the restroom. So another risk of sleep-related disordered breathing is to our cardiovascular health. And when we're looking at this graph, this lower red line is showing the risk of severe obstructive sleep apnea. And what we find is that over this period of time, this 15 years, there's a 45% increase of cardiovascular mortality with those patients who suffer with severe obstructive sleep apnea. And so we're not even talking about other conditions that can be exacerbated like cancer or diabetes or other chronic systemic inflammation disorders. With maxillary expansion, we're able to improve the upper airway as well as improving the facial development. And in so doing, as we're widening that maxilla, we're creating a better nose volume to be able to breathe better through the nose. We're improving the sinuses' ability to drain, and we're improving tongue space to create a better airway space for better breathing and better sleeping. In doing so, we're able to overcome a lot of the symptoms that tend to lead to sleep apnea and what we call TMJD disorder and other serious health problems. And so with maxillary expansion, one of the common things that we see with our patients who come in and they've been suffering with breathing, they tend to also suffer with a lot of pain in their jaw joint. And the reason is that instead of growing down and forward with the jaws, if we start to get a little bit locked and trapped, and that lower jaw gets locked and trapped, and over time it just continues to get just pushed back. So what it does is that joint gets pushed back a little bit further back here, and in the movable space where our jaw wants to be able to open, it should be sliding and gliding along a disc. But when that physically gets pushed back, it's no longer able to capture that disc as well. So what happens then is that it gets pushed off the disc that's in front of it. They open the jaw and there's a clicking sound. And then when they close, it pops right back off. And over time, if that's not addressed properly, it can lead to a lot of joint dysfunction. Whereas when we're able to expand those jaws and be able to help the lower jaw get into a better position, that disc is able to be captured a whole lot easier and be able to resolve a lot of the symptoms that patients suffer with TMD. Now, these are a few of some examples of our patients where, looking at the left, what we're seeing here is these yellow arrows are pointing to a very cloudy sinus. And so there's a lot of mucus that's just building up in the sinus from chronic sinus issues. When we are able to expand the maxilla, it helps to decompress the sinuses and allow them to drain better, as we see with this photo on the right. So what this is just kind of looking at the patient from the front and just a slice through there. And those sinuses are black and completely wide open. And we see this repeatedly. So as we look at this one image on the left, their right sinus is completely blocked compared to their left sinus, which is open. And following treatment, their sinuses were a whole lot more open. So where all this comes from is a gentleman by the name of Dr. Dave Singh. And he was the pioneer of being able to understand that these stem cells actually exist in between these sutures, and that these sutures, these joints, are not closed. And what he found, he's an orthodontist by trade, but had more of a specialty in dealing with craniofacial, cleft lip, and craniofacial disorders. And so as he was doing this research, he found the evidence of these stem cells in these sutures, and also found that around the teeth are stem cells as well, hidden inside the ligaments. This research, he was able to help develop this appliance that stimulates the stem cells. And that's what we use in our office. And so these appliances, when we look at them, these little curly springs, when they're contacting the teeth, they start to be able to turn on those stem cells around those teeth. And we incorporate jaw support as well, so that as we're going through treatment and expanding the jaw, we can be able to give relief of the immediate symptoms that people suffer with their sleep. As this appliance is working, we want our patients to be able to wear them for about 14 to 16 hours a day over a 24-hour period. And that doesn't have to be all in a row. But if you think about, we're wearing this to sleep, so that's 8 hours there, and that remaining time can be worn, 30 minutes in, an hour out, a couple hours in, an hour out. And what that's doing is that when it's in the mouth, it's helping to create pressure. And when it comes out, it's creating relaxation. And that pressure and relaxation cycles are what help to turn on those stem cells to be able to build bone. Another option that we have of being able to improve tongue space is using clear aligners. And so clear aligners have been around for a couple decades now as an alternative of using braces. one of the common methods of using clear aligners is to put these bonded buttons on the teeth and to also make space in between the teeth, by kind of filing 2/10, sometimes half a millimeter in between the teeth to create space. And then the clear aligners move all the teeth together. With our airway protocol of using clear aligners, rather than having a retractive approach where we're pulling the teeth in tighter towards the tongue, taking away that tongue space and making the tongue go to the only space it has left, which is the throat, we do the opposite. And we move the teeth outward, doing expansive movements, so then we create that perfect parking spot where the tongue needs to be able to go. And we do that without filing in between the teeth, without needing to put buttons on the teeth. Now, looking at Michael here, so this is one of the boys that we saw earlier in the slides. And after going through oral appliance therapy, what we saw with Michael was instead of continuing to develop this down and backward growth, he had that forward downward growth of the lower third of the face. And the jaws are the foundations for the teeth. The teeth are really the symptoms of the jaws. And so with Michael, he went from having a very, very deep bite, very narrow, that was trapping his lower jaw, to a very beautiful smile where we see there's a whole lot more lower display of the lower teeth, which is a sign that the lower jaw has been able to move down to the position where the muscles are happy, the joint is happy, and more importantly, it's creating plenty of tongue space. But what is so great about this is that when we focus on the root cause of the problem by developing the bone, we can be able to do this without needing to move teeth around with braces. So when we're looking at Michael's smile, it's beautiful, it's perfect, and all of that was done without braces. The best part, in my opinion, with Michael's treatment is that he went from having that airway space, it was more of a coffee straw, being very wide and well developed, more like a garden hose. And so his symptoms were able to taper off as he was going through treatment. He was able to sleep better and then ultimately start feeling better and not experiencing those same symptoms. So this was a patient in our office. He was 49 years old that we did the Vivos expansion with. And what we see is that when he was starting off, his airway was quite constricted, pretty much like a coffee straw. So looking that area behind his soft palate was about 5 millimeters, and the area behind the tongue was just shy of 7 millimeters. And as he went through treatment, in addition to being able to have an appliance to help to treat his immediate symptoms of sleep, growing that jaw set him up for success for the future, where that airway became so much more developed and became, instead of 5 millimeters, 10 millimeters behind the soft palate. And instead of 6.9 millimeters behind the tongue, 13 millimeters behind the tongue, creating way more space for air to be able to flow through. This is a kind of a volume rendering that shows that he went from having a very, very constricted airway to one that was wide open just after 9 months. This particular patient had a tremendous improvement, and it's also a very unique case. And so as we're looking at him, we see that adenoid tissue is quite swollen, and he has that coffee straw airway right behind the soft palate and right behind the tongue. As he went through treatment, that area opened up substantially. He was able to breathe better through his nose, and as a result, that adenoid tissue shrunk by about half. And it improved that space behind the soft palate, opened it up tremendously. But that area behind the tongue still stayed restricted. Why? He had an undiagnosed tongue tie. And so the very first thing that we want to be able to do is to open up that space so the tongue has plenty of space where it needs to go. After we create that space, we need to focus on the musculature of the tongue, where if it's been used to hanging out on the floor of the mouth, it's been used to not necessarily holding and stretching and kind of flexing its musculature to stay on the roof of the mouth. So we incorporate something what's called myofunctional therapy. It's basically like yoga for the mouth, physical therapy for the mouth. So it's helping to train the lips to be stronger, to maintain the lip seal necessary for nose breathing. It's able to strengthen the oral facial muscles and especially the tongue, as well as helping to deprogram a lot of the compensations that we start to kind of adopt as a result from having just a low muscle tone. And so this patient was one who, despite creating that space, we still need to do a little bit more work to get that tongue into that space once we create the parking spot for it. And so sometimes all we need to do is a little bit of myofunctional therapy, and that tongue is able to get up there and stay up there. But other times there can be what we call an undiagnosed tongue tie. And what that is that there's a tight band of tissue we all have called a frenum that keeps our tongue just bound to the floor of the mouth. Some of us, it can be bound a little bit more tighter than others. And when that's the case, we need to do what's called a tongue tie release, incorporating myofunctional therapy. And one of my mentors, Dr. Zoggy with the Breathe Institute, was one of the pioneers in really understanding the role of tongue ties in airway health. And what they found is that at Stanford, they were putting a lot of their patients through myofunctional therapy, and they were dramatically improving without needing to do any sort of surgical intervention. But some of them were not improving, and he found that it was a result of having just this deeper undiagnosed tongue tie. And he would release the tongue tie, and a lot of them would get substantially better. Some of them actually got a little bit worse with their sleep symptoms. And what they found is that when they were releasing these tongue ties, the tongue was a whole lot more mobile and had a whole lot more range of motion. But in some of these patients where the expansion wasn't done first, that tongue had nowhere else to go by being very mobile except into the throat space. And so what we always do first is create that parking spot for the tongue. We then focus on the musculature to strengthen the tongue with myofunctional therapy. And then if there is still just this tightened tissue that just needs a little bit more release, we do that release with a CO2 laser and follow it up with more myofunctional therapy to continue to help to strengthen the tongue and release it and hold that position on the roof of the mouth so we can completely remodel that airway. So understanding that there's a lot of different approaches that we can take to be able to treat these airway and these sleep issues, I encourage you to come in for a records appointment because all of us are very unique and all of our issues are unique. And as we take our records, we can be able to determine the best course of treatment to be able to help treat your symptoms, but also help to be able to treat the root cause of these symptoms. In our office in Colorado Springs, we have done more of these treatments with non-surgical Vivos appliances than anywhere else in the country, over 750 cases. And what we're seeing is that time and time again, our patients have an improved airway where after just 9 months of treatment, they're starting to have a bigger airway. And I would expect the treatment with these appliances typically takes between 1 year to 2 years, depending on how long someone can be able to wear their appliance during the day. And it is absolutely phenomenal in being able to improve their airway. So as we are looking at, this slide, looking from kind of a top-down bird's eye view, we can see that airway on the left is a lot more constricted, and that's one I don't want you breathing through compared to the airway on the right that's a lot more open in every single dimension. Now, in addition of being able to improve the airway, the upper jaw kind of is also what helps to establish our face. And so, one of the common things that we see with a lot of patients is that they have an improved facial appearance as well as that upper jaw develops. So, looking at her, we see, a lot of changes just month to month over that 12 months that she's in treatment. And it's not something I can guarantee with everybody, because if I guarantee it, then it wouldn't happen. But it is common that a lot of our patients notice these facial changes. And so she had a little bit more of that classic mouth breathing appearance, a little bit more narrow with a longer face. And as she went through treatment with her Vivos appliance, the upper jaw became wider and it allowed her lower jaw to rotate and come more down and forward. And in doing so, it gave her a better foundation for her eyes. Whereas when the jaws were a little bit pushed back, it allows the eyes to look a little bit more bulbous because they don't quite have as much bone support. But as that upper jaw develops a little bit more and the lower jaw comes forward, it gives better support for the eyes. And this is actually one of our doctors in our practice, Dr. Kevin Goles. He was his very first patient. And you can see here that when we're looking at before treatment, he had sort of the classic down and back or just straight down growth of the lower third of the face. And as he went through treatment, he was able to develop more of a jaw and moving things down and forward. And Dr. Goles didn't quite fit the classic phenotype, classic appearance of someone who has obstructive sleep apnea. And so at this time, he was very, very fit. And yet, at age 27, he was diagnosed with high, moderate obstructive sleep apnea. And the result of it was just having an underdeveloped foundation, underdeveloped jaws, which then kept the tongue pushed back into the throat. And so what you see here is that as he went through treatment, and that tongue had a whole lot more space as a result of the jaws moving more forward and down, it opened up his airway and was able to resolve his sleep apnea symptoms. The other thing that we notice here is when we're looking at the photo of him before treatment, he's holding his head a lot more forward to basically open up the airway. So when we struggle and have a more constricted airway, our posture gets influenced a lot by that, where we tend to move our head forward a little bit more with our chin a little bit higher, basically putting ourselves into a CPR position. That is done to just be able to open the airway. Now, as his airway improved, so did his posture. So when we hold our head forward, we're taking this 10-pound bowling ball that's suspended, and that puts an extra 10 pounds of pressure on our axial spine for every inch that that's moving forward. One of the other kind of tools in our tool belt of being able to improve snoring and sleep apnea symptoms is what's called night laze. So what the night laze is, it's a non-surgical treatment where we use a laser to basically help to allow the collagen to tighten up. It's basically like a facelift for the back of the throat. So with a lot of patients where they have a longer soft palate, that's an area for collapse, and that's where that snoring sound comes from. Like I said, it's non-surgical, we're not removing any tissue at all, and it requires no downtime at all afterward. Most patients feel a substantial improvement just after the first treatment, but essentially what it's doing, it's allowing that collagen to tighten up in the back of the throat to lift the palate upward as well as from the sides of being able to open up the airway even more. And so these are some patients who are in our office. We've done thousands of these treatments. And looking at this patient before compared to the patient afterward, you can see how much that soft palate lifted to be able to open that airway and allow for less obstruction of the soft palate into the airway. This patient, the very first photo that we see in the upper left is before the first treatment. That photo on the right is immediately after that first treatment. So within 30 minutes, that soft palate was able to completely lift. We then allow 3 weeks to allow that collagen to continue to mature. And as that's maturing over that 3-week period, it's tightening and lifting. So we see you back again for, another procedure 3 weeks later, and we do it again. So this patient, right at the start of 3 weeks, we saw an even higher improvement of the lift of the palate just by allowing that 3 weeks for the collagen to mature. And then again, right after her second treatment, huge improvement of being able to lift the palate upward as well as laterally to open up the airway even more. And it is very routine and expected to be able to get great outcomes of lifting the soft palate with all of our patients that we do this with. Now, at the Breathing and Sleep Center, there's me as well as a couple partners, so Dr. Kevin Goles and Dr. Eric Erlander. And combined, we have over 30 years of experience in treating sleep medicine using a number of different protocols, whether it's non-surgical maxillary expansion, clear aligner treatment to improve tongue space, myofunctional therapy to improve the tongue tone, or doing a tongue release if necessary using a CO2 laser. With that experience, we have done in our office more non-surgical expansion than anyone else in the country. And we have had patients who have walked away and they're feeling better, they're sleeping better, and their symptoms have tapered off completely. So as we've been discussing these symptoms and the root causes of it, if you feel that any of this rings true with you, please give us a call and make an appointment to come in for a records appointment, where we can be able to take all of the necessary 3D x-rays, photos, and home sleep tests to determine what would be the best way of being able to treat the issues that you struggle with. And I look forward to meeting with you.